Good afternoon. I'm Lorna Lucas, Director of Provider Education for the Association of Community Cancer Centers, and I'm eager to introduce Dr. Stephen Powell as our expert presenter in the 9th e-course of the series hosted by the Institute for Clinical Immuno-Oncology, or ICLIO. As you may know, ICLIO is an institute of ACCC, and it's the only initiative to prepare multidisciplinary cancer care providers for the complex implementation of immuno-oncology in the community setting. The ICLIO program provides a host of educational resources and tools such as these webinars, e-newsletters, e-learning module courses, tumor subcommittee updates, an immersive IO visiting experts program, and live meetings. Now for today's e-course, I'm pleased to introduce Dr. Stephen Powell, who's a medical oncologist and clinician scientist at Sanford USD Medical Center, which is part of Sanford Cancer Center, in Sioux Falls, South Dakota. Dr. Powell is focused on novel biomarker-driven clinical trials and experimental cancer therapeutics. While having a disease focus in head and neck cancer, he's interested in clinical trials evaluating novel drugs in a variety of tumors. Dr. Powell is currently the principal investigator of a community-based molecular profiling program for patients with refractory solid tumors. Additionally, he's actively engaged in translational and clinical research focused on immune checkpoint inhibitors and other agents focused on augmenting the immune response for the treatment of head and neck cancer. Dr. Powell also serves as a sub-investigator for Sanford Health National Cancer Institute Community Oncology Research Program, or NCORP. Now for a few housekeeping notes, please feel free to submit questions during the presentation to our presenter by typing in the question box on your dashboard. I will then pose all the questions to Dr. Powell at the conclusion of the presentation. This webinar will be archived and will be available on our ICLIO website, which is accc-iclio.org. Now I'll send it over to Dr. Powell to kick off our webinar.
All right, well, thank you very much for the introduction and the opportunity to participate in this webinar. We can go to the next slide. So I'd just like to start off with this slide because it really highlights the main point of our program and what our group feels about cancer care. At the top of being a clinician and a medical oncologist, I'm also a researcher, and I think that I find it very concerning that only 5% of cancer patients will go on a clinical trial. And that ranges anywhere from 2 to 7% on which study you look at, but nationally we don't do a very good job of getting patients on clinical trials. The majority of patients that go on clinical trials are being treated at large academic centers that really only constitute about 15% of our treatment centers. So 85% of patients are getting treatment in a community setting like ours. And I think in order to really improve upon these clinical trial enrollments and getting patients access to these newer drugs, we need to do a much better job of getting clinical trials into the community. So that really highlighted how we build our program around this, and we can go to the next slide. So the main objectives of my talk, I really want to explore how we sat down as an institution and decided to provide innovative cancer care in our setting. And I'll show a picture, but we cover a huge geographic area, and it's predominantly rural, which poses extreme challenges to try to deliver innovative cancer care. So that was one major thing that I'll highlight, how we developed our program. We'll talk a lot today about our virtual tumor boards, how we implemented this as a way to really improve patient access to novel therapies and clinical trials and really grow our clinical trial program. And then as this is an ICLIO talk, we will talk about how our tumor boards really expanded immunotherapy access in our population and in our community-based setting. We can go to the next slide. So for those of you who may not be familiar with Sanford Health, this is kind of a geographic representation of where we cover. And this is actually a map looking at different, I think, economic areas, but we actually use it to kind of highlight the area we cover. So the blue area is the area that we serve throughout Sanford. So we have 4 major cancer centers, one in Bemidji, Minnesota, one in Bismarck, North Dakota, one in Fargo, North Dakota, and then the site that I'm at in Sioux Falls, South Dakota, and now have started to work with cancer centers in Montana as well. So we cover a huge area bigger than the size of Texas that we have to provide cancer care to this entire region. So we cover about 200,000 square miles or more for patients. So many of our patients are driving 2-3 hours to come see us for appointments at any of our cancer sites. We have a huge number of hospitals in this network. We have about 43 hospitals and about 250 separate standalone clinics, and these actually encompass about 9 states if you count all the states we involve. And as we look at it, and this number is probably not accurate anymore, this number is back from 2013, we see between all these sites, not including the Montana sites, over 4,500 cases of cancer a year in this area. So fairly similar to what you'd see at a large tertiary cancer center like Sloan Kettering or MD Anderson. We see the same volume, but over a much more widespread population, which certainly poses some challenges when you try to develop your cancer program around this. We can go ahead and go to the next slide. On top of having a cancer care program, we also have a cancer research program throughout this entire network, and this is just a little bit more pared down geographic map showing our 4 major cancer centers. We were fortunate enough in 2014 to be awarded an NCI Community Oncology Research Program grant award. So we're one of 34 programs in the U.S. that receives NCI funding to open National Cancer Institute supported trials throughout our network. And this was based on our high enrollments in the past through these sites, with nearing 500 enrollments per year on National Cancer Institute trials. And we strive to try to deliver these NCI trials in this region and really get our patients access to these nationally recognized trials. On top of this, the institution themselves has really focused on trying to grow their basic and translational research program in this region. We understand that clinical trials are important, but it's also important to do some basic and translational research along with that to try to explore how do we improve upon our therapy. So they have funded a biobank program and throughout the entire system to bank human tumor specimens and blood, and also we have an NCI-funded translational basic research program here in Sioux Falls throughout the system. We can go ahead to the next slide. So I joined the cancer program here in 2013, and at the time, it was actually a very interesting time in cancer care. We were really moving away from clinical trials that were looking at, at specific disease types and more towards precision medicine trials. So we were looking at more trials like EGFR mutated lung cancer trials and ALK-positive lung cancer trials. So we were seeing the shift towards precision medicine, where instead of looking at a specific disease type, you'd be looking at a specific biomarker in that disease type, which really posed a challenge in our setting. And also towards the end of 2013, that was around the time we were seeing pembrolizumab and and nivolumab getting approved for melanoma. So we're seeing immunotherapy emerge as a dominant treatment option, and just a huge number of clinical trials in that area growing. And certainly these trials were much different and required a much different skill set to run these trials. They have different imaging criteria, different toxicities to evaluate. So this was something that was changing pretty rapidly. And in general, we were seeing a much more specialized approach. So most of the trials were multidisciplinary, requiring radiation oncology, surgery, medical oncology to communicate and collaborate in these trials. And oftentimes they were requiring biopsies and even during treatment. So as these were evolving, we had to keep all this in mind as we tried to evolve our program along with it. We can go to the next slide. So as we sat down as a group, we literally sat down with everybody that was a stakeholder involved in our cancer care team, from interventional radiology to surgery to radiation oncology, everybody. And we wanted to develop a better infrastructure to allow for specialized testing. If patients were going to need next generation sequencing to get on a ALK-positive lung cancer trial, we wanted to implement that here so that we could get it done as fast as possible. Certainly PD1 testing was starting to become important too. We wanted to develop processes to get all this done so patients could be streamlined on getting this testing done. And then also, as these tests emerge, they come out almost every month, every other month, where there's new data on this. We wanted a way to rapidly educate our clinicians on these and when you should be utilizing different drugs for a potential biomarker, what the rules are behind that, what insurance will and won't cover. So we wanted to explore how we did that in a rapid fashion. And we also wanted to rapidly screen our patients for clinical trials. If you identify a patient that has a unique biomarker, you want to get them access to that clinical trial if it's their best option. So we wanted a way to continuously do this as well. And then, of course, we wanted to incorporate our administrative staff and our pharmacy groups as well, so that when we do have a patient that has a rare tumor type or has a specific gene mutation or a need for immunotherapy, that we could get that covered for them. And we saw the best way to do this in a continuous process that could evolve over time was through our multidisciplinary tumor board. So when we sat down as a group, we really tried to change the way that we do our tumor boards to try to implement all these things into that. We can go to the next slide. So this is an example of how we started to do this. So we developed our first pilot, I guess, to try to change our tumor boards, and the way we used our tumor boards was our molecular oncology tumor board. So we understood that molecular testing was becoming very important. People were sending Foundation 1 testing KRAS reports kind of on their own, and what we were finding is a lot of providers wanted help reviewing these, and we were trying to review these at our general tumor board. And we decided to really use our molecular tumor board as a model to develop our virtual tumor board. So what we did is, throughout our enterprises, we basically together as a group decided on a day to sit down together and review these molecular tests and the patient cases. And for this group, we sat down and involved everybody we could think of that would be important in this. We included our genetic counselors to help understand some of the genetic alterations on these molecular tests. We had all of our oncology subspecialists, so our surgeons were there, radiation oncology were there for that particular tumor board if needed. And of course, our medical oncologists were the primary group that were interested in this. We actually are fortunate enough to do some in-house molecular testing, so we do have a clinical geneticist and molecular pathologist here, so we did include them in this as well to help interpret some of the tests. And of course, our pathology group was there to help review whether or not a patient may have enough tumor biopsy available to send for this type of testing. We do include our pharmacy group here. We have a pharmacist who her chief role is to help try to get prior authorizations done for medications, and when it is not approved for insurance, trying to get compassionate use through the pharmaceutical companies. So they do attend to help get background information and also literature available so that we can try to get drug covered. And of course, one of the chief members of this was our research team. So our clinical research coordinators and project managers for our research staff attend every one of these molecular tumor boards at all of our sites to help review the findings and screen patients for trial. And since we have 4 major cancer centers, we made the decision that we didn't want this just at one center. We wanted this at every center. So we made this weekly video conference tumor board. And actually, what we actually were able to do through the use of our Skype program that the institution already had for live meetings, we were able to offer Skype visits. So a single physician could call in from their office over the tumor board time and present their case, even if they're at one of our small outreach clinics that we might have, if they're not even at one of our rural cancer centers. So this was very, very available. We actually included guest experts as well. So we have a collaboration of Sanford Research Institute in La Jolla, California. Their scientists actually will call in from time to time to listen in on cases and provide insight from a scientific level. So it was basically a very accessible tumor board that included all these specialists to sit down with one goal in mind, is to review these molecular tests and help find better treatment options for our patients. And then at the end of the day, by working with our compliance teams, we were able to find a way to document this and get a final note that would go into the EMR, so that even if a physician couldn't be there, if they didn't remember what was said at the conference at that particular date, this was documented in the patient's chart so that they would have the treatment recommendations the group provided. We can go ahead to the next slide. So we actually, as part of this, intentionally decided, well, if we're going to implement this, let's do a research study with it. Let's actually see if we're doing anything with this beneficial to patients. And we had a study that we titled Gemma, which there's a national clinical trial code here that we implemented with this. And it was a prospective study that said, basically, if we're going to use our molecular tumor board, let's go ahead and see if we actually are able to match people up with treatments based on their genetic findings. And what we were able to find, which was quite striking, is we had about 109 patients that were eligible and went on the study. And out of these patients, depending on what testing was used or what testing identified, about 90% of the time, we were able to find a potential actionable target, either the drug that's in clinical trials or for off-label use. And what we were very happy about our results is that we were actually able to match patients up with genomic match therapy. So if we found a molecular marker that suggested there was a reasonable treatment option for this patient, more than 1/3 of the time, the patient went on genomic-directed therapy. And these were, just to give you an example of these types of patients, these were patients that had already progressed on all standard treatment and really had no standard treatment options, and the only option would be clinical trial. So we were able to match patients up either with off-label drug or, as you can see below, at 16% of the time, a clinical trial that would match up with their genomic target. Which, just to compare, again, our group is much smaller than these other institutions, but Cleveland Clinic did a report, some of their matching rates, and then MD Anderson as well. We felt this was, a huge success for a community-based program. And part of the reason why it was such a success is that as we built our molecular tumor board, we actually built our clinical trials program around it to really match patients up with treatments that may benefit them. We were actually able to go back and audit whether or not a patient had a specific gene mutation, and then try to screen for trials for that particular patient and bring them in. I think one of the biggest things that was kind of striking from this and unexpected was the importance of immunotherapy. We saw actually some of the patients that got the most benefit on off-label drug or compassionate use drug were the patients that get immunotherapy, and I'll talk about those on the next slide. So this paper came out about a year into the development of our tumor board. I remember being at the American Society of Clinical Oncology meeting when it was reported. This particular paper looked at PD1 blockade and tumors with DNA mismatch repair. So basically, this study identified a subset of patients that had a genetic change and had hypermutable tumors would respond to PD1 inhibitors. And this came out around the same time as our tumor board was moving along, and we actually were able to educate our group in real time on the findings on this. We can go to the next slide. So from the study, I think it was mostly talked about was the colorectal cancer patients. And in the study, they saw that basically if patients had DNA mismatch repair colorectal cancers, they had a substantial benefit from PD1 inhibitors, but if they had a mismatch repair proficient tumor, they had zero benefit. And one of the more interesting aspects of this trial actually was the aspect that there was a lot of non-colorectal cancers on this. There's patients with other tumor types that had benefit, and in those patients that had DNA mismatch repair, 71% of these non-colorectal cancers actually had a response. So at the time this was presented, it was suggested as a potential new biomarker for immunotherapy. We talked about PD1 for PD-L1 expression for PD1 inhibitors at the time. This was kind of a new idea that perhaps molecular tests could lead us down the path of immunotherapy. You can go ahead to the next slide. So we were actually able to use this in real time, and this just displays how important this tumor board was. This data came out in early June of 2015 at the American Society for Clinical Oncology meeting, where several of us attended, and literally the next week in clinic, or in our molecular tumor board, we reviewed this case. And this was a patient that had metastatic lung adenocarcinoma, and he had progressed on all standard treatments for his lung cancer, had been through every chemotherapy, had actually been on a couple clinical trials and progressed. And we put him through our molecular tumor profiling program and actually identified a number of mutations, one of which being a BRCA mutation, but the one I have highlighted there is an MSH2 mutation. So having been at the conference at the American Society for Clinical Oncology meeting and hearing about these cases of microsatellite instability mutations and responses to immunotherapy, we were able to look into this gene a little bit more as a group at our tumor conference and identify that this patient actually had an MSI high lung cancer, which is pretty uncommon and hadn't been really reported before. So because of that and the data that we were able to get from the American Society for Clinical Oncology meeting, we were able to get this patient access to nivolumab. At the time, it was only approved for lung squamous cell carcinoma, but we were able to present to his insurance company this data and this molecular test, and then our group's opinion, and they were agreeable to cover Opdivo for this patient. And he received just a few rounds of therapy and had an over 75% reduction in his tumor burden. And he actually, it's now been just over a year and a half since he started therapy. He's actually stopped therapy as he's done so well, and actually is still doing quite well in regards to control of his cancer. So this is just one of our major successes with real-time education of providers with data and on these biomarkers to get a patient access to drug, and he's had a great result from this. We'll talk about another case on the next slide, which is a little bit more graphic, but we'll go to the next slide. So this is another patient who actually had a metastatic cutaneous squamous cell carcinoma. So this was a skin cancer, And this particular patient had the first picture on the upper left, you can see he had a skin flap after he had the tumor removed, and unfortunately it grew extremely rapidly back in that area and actually started growing into his ocular cavity and basically destroyed his eye. And then actually on the PET scan, you can see there he has a lung metastasis in the right upper lobe. So he actually went ahead and had radiation to that area, and the tumor grew through radiation therapy. So really, he was without any treatment options for this disease. There's not a lot of great standard treatments. There's some chemotherapy regimens that have modest benefit. But again, we were able to put this patient through our genomic sequencing program, and we identified a MLH1 mutation, which again is associated with microsatellite instability. We were able to confirm that he had a microsatellite unstable tumor, and he was able to get access to pembrolizumab through compassionate use programs, and again has had an exceptional response. And this patient as well has been on therapy for over a year now with a near complete response. And actually we just published this as a case report that should be out shortly for review. So again, it just shows the importance of reviewing these patients in a format that you can get multiple providers involved and you can educate in real time and get patients access to drug. And in this setting, I think it was really helpful to have a pharmacist there because they were able to help review this data and get the literature to present that to the company to get access to the drug. We can go ahead to the next slide. So through this program, we had the first kind of taste of how you can change your molecular tumor board from a site-specific tumor board and in a general tumor board to something that can actually be done at multiple institutions in real time. So when I first started, we had really evolved from that general tumor board, and we'd been doing single institution specialized tumor boards. We had at our Sioux Falls site, we did a GIGU conference, we did a hematologic conference, we had a neuro-oncology conference, we have a large head and neck group, so we had our head and neck and conference and our lung and thoracic and breast and GYN conferences, and these were really closed off to those specialties at that specific site. We did not communicate these across to all of our other sites typically. So seeing our success in our genomic or molecular tumor board, we said, why don't we do this in a different disease type and see if we can change the way our program is around that particular tumor type. And because we have a very strong basic and translational research program in our head and neck tumor type, we actually decided to expand our multi-institutional tumor board to our head and neck program, and I'll talk a little bit about that as well. We can go to the next slide. So again, at the time, we were running our molecular tumor board, and at the same conference we were hearing about MSI high tumors and their response to PD1 inhibitors. We were also hearing the story of immunotherapy and head and neck cancer. And at that particular conference, Keynote 12 was being reported, and their outcomes in head and neck cancer were being reported. And this is just an example here. And starting at the left, you can see a gentleman that had a recurrent metastatic head and neck cancer with severe skin involvement who received pembrolizumab in that study and actually had a tumor flare. They thought initially maybe he was progressing, but decided to keep him on therapy, and then eventually 3 months later had a nice response to treatment, and then 6 months out had a near complete response. And I was at this talk at our ASCO meeting, and we were quite impressed with the response seen. And really, for patients in this setting, we had no treatment options and really wanted to get access to immunotherapy drugs. So, seeing this at ASCO and thinking about our tumor board and our program, how we could maybe use our tumor board as a more wide net to capture patients for these trials, we went back home with this in mind. And we can go ahead to the next slide. So we sat down as a group and really decided that we wanted to reformat our tumor board so that we could improve access to some of these novel agents. So our two main hubs for head and neck cancer surgery are at Fargo and Sioux Falls. We have about 5 or 6 surgeons between the two sites that predominantly do head and neck surgery, and we have medical oncologists that focus on that. And we wanted a better way to communicate across to these two sites, but also to include our other smaller research sites, our Bemidji, Minnesota, and Bismarck sites. So we basically took the same model we used for our molecular tumor board and changed the way we do our head and neck tumor board and built a video conference tumor board that happens every week. It actually happens right after our molecular tumor board so that we can keep the video link up and keep the providers on. And through this, we were able to really identify our patient population and where we had trial gaps. We were able to see, where do we need these immunotherapy clinical trial options for our patients, and how do we build our program to serve our patients the best. And that really changed the way we have run our trials program. And we can go ahead to the next slide. So this is our head and neck program, or where it went as a group. So we, as a result of this tumor board, were able to really expand our immunotherapy trials program. So these are just 4 of the trials, and we've actually now added an additional 2 to this list here of immunotherapy focused trials for our patients. And we've been very successful in achieving our enrollment goals on these trials through this network. In fact, I have providers that will call me from our Bismarck site with a patient that is potentially eligible for one of the trials, and then we're able to help get the patient transported down to the site if they are a match. And the beauty of the video conference trial is we're actually able to utilize our clinical research staff to pre-screen the patient before they even come down to see if they'd even be a potential candidate for the trial. So we can really expedite their travel. And growing our head and neck program has only grown the rest of our programs even more. I mean, you look at all the other trials that we have open, and again, this is probably outdated. I think currently right now we have over the next year we'll have over 20 to 30 immunotherapy trials in different disease types throughout all of our sites, just as we expand our program. So it's been a great success at trying to broaden our clinical trials program in immunotherapy. We can go ahead to the next slide. Through this, it takes a great deal of support outside of our organization. Certainly industry is extremely important. As we built our tumor board, one of the best parts about being able to get this real-time data is you can go back to the companies and say, they'll ask, how many patients of head and neck cancers do you see? We have this clinical trial. Would you be interested in it? And you can give them those numbers in real time. Here's how many we review every week at our multidisciplinary conference. We've been able to really work with a lot of these companies to grow our program, and then even through the NCI and the NCORE, our base for clinical trials, we've been able to try to identify patients that may best benefit from clinical trials. So these partnerships are key to this, and we definitely have great communication through our clinical research staff in these sites. You can go ahead to the next slide. Through this too, we've now identified populations where we want to develop our own research. So I was always taught that the best clinical trial is the clinical trial that you develop yourself for your own patients, and we've done just that. And head and neck cancer, we saw a dire need for better definitive therapy for our patients, and the standard of care has been chemoradiation for years. And through our tumor board, we were able to identify that we probably see 50 to 60 patients a year that go through definitive therapy throughout our program, and really we have no trial options for these patients. So we were able to submit grant application and get funding through Merck to run a clinical trial using pembrolizumab with chemoradiotherapy for our patients. And I think our tumor board was key in this because we were really able to know our population, and we were able to identify the patients that are eligible for this. And the study is actually enrolled quite quickly, and we've just reported our interim results at the Society for Immunotherapy meeting just a couple weeks ago. Also through this, we talked about our molecular tumor profiling program and our Gemma study that we did. That was a pilot study. We saw major benefits to our patients with that program and matching it with therapy. So we decided to evolve that program and really answer some more tough questions about how we use molecular profiling. We launched our program Compass, which is basically a way to follow outcomes of patients that get genomic testing and are presented at our tumor conference. So basically, any patient that is presented at our molecular tumor conference has the opportunity to sign consent, and we will follow their outcomes. And we're going to look at a number of things, including patient outcomes, but also cost of care and how molecular testing may either decrease or potentially increase cost of care, because we feel that this data is very important as we start doing a lot of specialized testing. And of course, immunotherapy is going to be a subset of those patients as we integrate PD1 testing into that paradigm. We can go ahead to the next slide. We've also been able to work through this program to grow our other areas of immunotherapy. Certainly, immune checkpoint inhibitors are dominating the landscape, but we're starting to get into the realm of therapeutic cancer vaccine, and we'll be launching a trial in breast cancer in the next month or two, using a novel therapeutic cancer vaccine for that, because that's a population we see a large number of here, a large number of patients we don't have trials. And we'll also be launching one of our first oncolytic viral therapy trials here as well, as we learn more about these options. We can go ahead to the next slide. And as I mentioned at the beginning, I think that anytime you're going to do clinical research and have a strong clinical research program, it's important to go back to that translational step. I think that right now the area of great debate, which we hear a lot about, is immunotherapy biomarkers. So who are the patients that are going to benefit from PD1 inhibitors? For diseases like head and neck cancer, only about 20% of people or 30% of people will have a durable response to these drugs. So who are those people, and how do we get those patients access to those drugs right away? And then you need to be able to identify the patients that don't benefit from drugs so that you can treat them with some other agent that's more efficacious for them. So through this, we've been able, our research program, we've been able to build our immunotherapy biomarker research program and biobank. And also we've been able to help develop kind of an experimental therapeutics line where we actually look at novel immunotherapies in the lab. And because we laid the groundwork to build this along with our tumor board and gather this prospective data, we've been awarded a grant to really help explore some of these immunotherapy biomarkers and novel drugs. You can go ahead to the next slide. At the end of the day, when we sit down as a program, and I think when we thought about how do we build our virtual tumor board structure, we really wanted to have a program that expanded access to novel anti-cancer therapies through clinical trials. We wanted to use our tumor boards as a mechanism to screen patients and get them access to these trials and try to screen for the best trials that we can get. We also wanted to try to use the tumor boards to improve the precision of our novel therapies. So really, how do you use biomarkers in real time to try to match patients up with therapies that are the most evidence-based and best for their therapy? And as part of this, we actually have developed a genomic steering committee now that actually reviews all of the molecular testing that's done either on-site or that we send samples out for. And we've actually developed evidence-based guidelines here on how we assign or recommend treatment. So if a patient is recommended to have a treatment through our molecular tumor board, we actually give the level of evidence for that based on the literature that's available. And we also, at the end of the day, want to try to provide any, innovative cancer care in the community setting. As I mentioned before, only about 5% of patients go on clinical trials in general. We want to increase that number in the community because I think that's where we'll make the biggest impact in improving trial enrollments and getting patient access to novel drugs. And of course, we want to develop drugs that are going to be the best for our patients in this setting. We can go to the next slide. So at the end of the day, I think that what we initiated here was a solution to try to get our patients access to novel therapies in this rural environment. Our patients are already driving 2 or 3 hours to see us for clinic visits. Our molecular tumor board and our head and neck tumor board are now video conference tumor boards that we can have the provider at that site present their patient and decide whether or not the patient needs to come here for a clinical trial. So hopefully we save time for the patient and expense for the patient by screening them and helping them look at the best options at their sites through this mechanism without having to have too many clinic appointments. We've been able to really improve provider education. So every one of these conferences, it's constant where we're talking about a new paper that's been published that talks about a specific biomarker. We're talking about new data that may be presented. I mean, just the last week, we presented 2 cases of lung cancer that had PD1 testing positive, and we reviewed the KEYNOTE-24 trial and the use of pembrolizumab for upfront metastatic lung cancer. So I think that this provides real-time provider education on these biomarkers, can help improve education for all the staff involved, as well as improve patient access to these options. And I think, at the end of the day, our program has really helped our immunotherapy trials program explode. We were talking at a couple of these national meetings, both at the SITC meeting and at the ACCC meeting, that there's hundreds of immunotherapy trials coming out in the next couple of years, somewhere between 500 and 800 clinical trials, and we have to decide which trials are going to be best for our patient population. And I think that the tumor boards let you review your population, decide what patient population do you need these clinical trials for, and then also you can review the trials when you're presented them and see, is this something that scientifically looks like something we think is reasonable for our patients, and it'll help you stratify what type of research program you want to have. And we can go ahead to the next slide. So, I mean, that's a summary of our program. I think that, again, at the end of the day, it wasn't terribly expensive to implement this. We were able to utilize a lot of our same resources we used for regular video conference meetings, and we just use it in a manner that allows our providers to communicate with one another, and our research staff to communicate to one another to, at the end of the day, help the patients. And at that, I'll stop and I'll take any questions.
Great. Well, again, thank you so much, Dr. Powell. I did also want to mention before we get to the questions portion, I just wanted to give an acknowledgement, and again, congratulations to Dr. Powell's program at Sanford. They were our 2016 ICLIO Innovator Award winners. So again, I think from the presentation, it's very clear that there's a lot of innovation occurring there. So again, congratulations, Dr. Powell, and to your colleagues. And with that, I do see some questions. So again, if you have any questions that you'd like to submit for Dr. Powell to answer, feel free to type it in on your dashboard, and I can ask him. So a question came in about travel. So everyone knows that can be an issue, especially with regards to enrolling patients in clinical trials. Is your institution providing any resources to help patients so that they can travel to their clinical sites?
Yeah, I mean, so that's a huge issue when you're at a community site, and we've been, fortunately, when it comes to industry-sponsored trials, when we're in the budgeting and contracting process, we're able to actually sit down and ask for some sort of support. Either it's typically like a gas card or some sort of reimbursement for the patient for a hotel stay for this, and it's something you really have to think about ahead of time. So when your site's going to think about opening this trial, they have to decide how many visits it's expected that patient's going to be there and budget for that, and you just ask for it. And it's something that we've been very strict about. We know that our patients have to travel, and we want them to be able to stay in a hotel. And we're fortunate enough the hotels by our clinic here do provide discounts to our patients that are coming for active treatment, so it's affordable. And the other thing that you can't downplay either that really has been helpful even in just general clinical care is for our patients that live locally that have to travel even half an hour or so. We do have the American Cancer Society that has a ride program of volunteers that have helped. So I think we implement all those processes to try to get patients travel here. But with a rural site like this or a community site, people will drive. I think the longest I had somebody drive to come see me for a trial was 7 hours. And he would drive down the night before and then drive back after his treatment for the trial. And for him it was worth it. The trial actually helped him a great deal. He had metastatic recurrent head and neck cancer, but if we didn't have that budgeted in for him to stay overnight, I think he probably couldn't have done it.
Okay, great, thanks. And then as far as PD-L1 expressions, is your hospital having any issues with regards to PD-L1 expression testing? Are there any issues with acquiring enough tissue sample for the biomarker test, or if so, how's your institution addressing that?
Yeah, well, so I mean, for PD-L1 testing and all testing and next generation sequencing testing that's done, you definitely have to have enough tissue for it. And that was something actually when we developed our first run at our molecular profiling tumor board, our molecular tumor board, is we had our pathologist there to help us review cases. Of what we found is through our standard biopsies that we were doing, oftentimes we were not getting enough tissue. So we actually, through our tumor board, were able to work with our interventional radiologists and other doctors and actually say, here's what we need for this type of testing. And they were able to change the way they do their biopsies. So when they're in getting their biopsies, typically now, they're during the same procedure, they're able to get they are able to get adequate tissue for this type of testing. And really our success rate for molecular testing has been over 90% now through that process change, just by having those providers at that tumor board and seeing how important it is for the tissue. So that part of it has changed dramatically through our program. The issue of PD-L1 testing, of course, is where do you get it done? How do you get it done? We're still waiting to decide whether or not we want to bring it in-house. We have the capabilities to do it, but there's so many different assays out right now, and the one that's approved for biomatch therapy is the Merck assay. So what we've done is worked with our pathology department, and we do ship it out right now, but we're in the process. Hopefully, once the PD-L1 blueprint data comes out, hopefully we'll implement it in-house as well.
Okay, great, thank you. And then how reliable do you think PD-L1 expression testing is for predicting a response in patients taking these checkpoint inhibitors?
Yeah, again, that's the other great debate is, should we be excluding PD-L1 negative patients from PD-1 inhibitors? And I don't think we should. I think that PD-L1 testing it's kind of that biomarker that says if you have a lot of it, you're very likely to have benefit from therapy. Again, that's not even 100%. You could have 100% PD-L1 expression in your tumor, and maybe you don't respond to therapy. I think it's definitely more complicated than that. And you have to remember how these drugs work. These drugs, you have to have immune cells in that area, in that tumor microenvironment, and they have to be activated and willing to attack or be in a position that they can actually do something and be cytotoxic. And these drugs work to basically activate these cells or to take them from this exhausted state to an activated state. If you don't have the T cells there, it doesn't matter how much PD-L1 expression you have, probably. So I think that we're going to probably have some more sophisticated biomarkers in the future. Certainly there's data looking at RNA sequencing, and there's some other assays looking at peripheral blood response and how what's going on in the T cells on whether or not they're activated or inactivated. But I think for right now, PD-L1 expression should be used as the data comes out. So if we have data that says you're PD-L1 positive and you may benefit from upfront immunotherapy rather than chemo in a randomized setting, you should use it, but I wouldn't exclude anybody from treatment just because they have a PD-L1 negative tumor.
Okay, great. Thank you. All right. Well, I think that's the conclusion now of our webinar. So again, thank you, Dr. Powell, for the engaging presentation, and thank you all to our audience for participating. Both the webinar and slides will again be available on our website at accc-iclio.org shortly, and you'll also receive an email as a registrant with the link to access it. And also, please register for our upcoming webinars. On December 1st, Dr. Michael DeLeo will present on the roles of radiologists with immuno-oncology. And on December 5th, Dr. Sigrun Hallmeyer will present on how to model your emergency response to triage IO patients. So again, thank you, Dr. Powell and everyone, and please enjoy your holiday.
Thank you.